process a little bit of what happens when the immunodeficiency virus attacks the body. Let me move my microphone over here a little bit. So this fried egg looking thing is supposed to be a lymphocyte. And you know, of our white blood cells, does anyone know what percentage are lymphocytes?
5%.
Not right offhand?
30.
30, 40.
30 to 40%, that's correct.
I just threw that.
And as far as, of
Oh, is it?
the cell
Oh,
count,
I don't know.
do you know what a cell count you would expect to see in lymphocytes? 15
to 4,000.
1,500 to 4,000? Yeah.
Yeah, that's pretty close. 1,500 depends on which reference you use to 4,000
I can't really
or
see.
4,500 lymphocytes, I think, per millimeter squared of whole blood. Very good. So here's our lymphocyte, and of the lymphocytes, there are subdivisions, T cells. Some of those are different types of T cells. Some of them are CD4 helper cells, and they are kind of like a drill sergeant. They call all the other white blood cells and get them going, moving, so they can attack the virus or whatever the invader is. The CD8 cells are another subtype, and they're actually a suppressor. And they keep us from overreacting to things or having allergic type over-the-board responses. So there's a ratio that we may talk about a little later, the CD4 ratio to the CD8. You want 2 CD4s for every CD8 or a 2-to-1 ratio. If you don't have enough CD4s, it's more like a 1-to-1 ratio, and that's a bad indicator. So the way I think of the HIV virus is kind of like an evil genius. It comes along, it invades the cells, it starts growing the virus and replicating, and it really takes over our fighting cell and turns it into a soldier for the virus. So the virus replicates, and where one invaded, it will destroy our lymphocytes, so it's dead, and then thousands will emerge of HIV. So they will go on to invade thousands of our lymphocytes and do the same thing. So I think of it, that's the way I think of how it works. Our medications, which we will talk about a little later, but some of them keep the virus from invading the lymphocyte. Some of our antiretroviral medicines work at that point, don't let it in. Some of them interrupt the replication where they start growing and splitting. Some of them keep them from leaving. So they work in different ways, and that's why people have to take a combination therapy. Early on in the 80s, they had to take lots and lots of different pills. Now we have combination pills, so they don't have to take so many pills, but they have to take several types. So I'm going to flip over to my computer slide. Very well. Okay. All right. So, this is what we just kind of talked about a little bit. Whoa. That's a little bothersome. Hope that stops soon. suggested I eat steak and start over. So I eat steak, the evil genius HIV virus, and what's going on. So this is kind of what we just talked about. We just looked at the visual there. The virus gets into the cells. It really likes the CD4 cells in particular because they have a nice docking station, they call it. They could Star Trek and all those space movies where they have to dock. Our viruses have to too. So then hijacks the cell, becomes a factory. As it goes on, there are more and more infected lymphocytes and fewer and fewer healthy ones naturally. And the difference between HIV and AIDS is, well, can one of you tell me the difference between HIV and AIDS?
I don't know if you can hear them because it's quiet. They're saying the T cell count is the difference.
Okay, that's a big part of the difference. You can have the HIV virus and never get sick. It doesn't have to lead to AIDS, and I think Magic Johnson is a good example of that. He's been HIV positive for a long, long time. When you think of Charlie Sheen, he looked pretty sick when he first announced that he was HIV positive. I think he lost a tremendous amount of weight and had already probably, of course, we don't know the details of his count, but the presence of the opportunistic infections or AIDS-defining illnesses has a lot to do with that too. So you can have HIV and never make it to AIDS, but you cannot have AIDS without having the HIV virus. So, and then we'll go into a little more detail with that. Can you go back to that? So, Stillwater, what does, well, it says right here, I'm not gonna ask you what's right in front of you. So lymphocytopenia means that we have a very low number of all types of lymphocytes. We also have when we're infected with HIV, our antibodies do not work properly. Our macrophages, which are those cells that like to encapsulate and eat the invading organism, they don't work properly either. And we get opportunistic infections and diseases. These are often things that are normally in our environment and never cause any problem. We're exposed to these things all the time if we have a healthy immune system. They're even on our skin, we walk through the soil, we're in contact with fungus and things that, yeast and things that would not normally cause us problems. But when your immune system isn't working properly, then you tend to get sick. And there are charts we'll look at that list specific opportunistic infections that are what they call AIDS-defining conditions.
Can you go back?
Can you go back and real quick? I'm gonna
Okay. So on page 339, there's a good diagram that talks about, we haven't got into the drugs yet, but when we do, that diagram shows you a little bit about all the different kinds of antiretroviral medications and how they work at different parts of the cell cycle, which I think is pretty cool. It's, I like the visual of that. Okay. So classifications, there's a classification system. The stage 0, and this is this is straight out of your book, it's on page 339. So, it said the first 6 months after you have a positive HIV test, you're stage 0. Stage 1, you have a CD4 count of 500 cells per millimeter squared or better. You have, that percentage is 29% or better of your lymphocytes. And you have no AIDS defining illnesses. So, I don't really think I probably have to read each of these to you. Stage 2 is exactly as it says, and like I said, it's on page 339. Stage 3 is a little trickier because it's a CD4 count below 200 and below 14% with an AIDS-defining illness. However, your count can actually be better. Maybe your count's 250 or 300, but if you have one of those AIDS-defining illnesses, it's still considered a stage 3. So you may have to read that one a couple of times in your book and think about it to get that down. And then stage 4, somebody presents, they're sick, it's discovered they have HIV, they're HIV positive, but they have no idea how long they have been that way. They don't know when they were infected. And maybe they haven't even got any lab work back yet. Okay. So AIDS-defining conditions, I think I was saying AIDS-defining illnesses or infections. This is the newer term is AIDS-defining conditions, and it's abbreviated sometimes ABC. There's a table of these on page 340. There's a pneumocystic gyrovici, which is from the soil, it's a fungus. That's pretty common. I imagine most of these are common. There's some that I have encountered in my nursing career, and that I listed a couple of those. I said Mrs. A. The first person I took care of who was sick with AIDS came into St. Mary's ICU. She had a couple of these actually. And it took a while to get the lab results back because they didn't know what to run on her. She was just critically ill, on the ventilator. Her blood pressure was probably 50 over 30 most of the time. We thought she was going to die practically every hour that we took care of her, but she did hang on a couple of weeks, and eventually we realized the doctors had run all the tests they could think of. They did not. This was in the 1980s, and I think she was the first case in Garfield County, actually. She was a woman. She was around 60 or so. And at that time, this was thought of as a gay Caucasian disease, mostly in New York and California. So our doctors did not run the right test for a little while because she didn't fit the parameters. But it turned out that she had had a blood transfusion about 5 years before we tested the blood. So, and if you get the disease in a big dose, which she did, when it kicks in pretty hard. And then the cytomegalovirus retinitis, I took care of a patient, Brad is not his actual name, but also in the late 80s and early 90s, the state created a group of employees to do catastrophic case management. And due to some politics, instead of hiring a nurse in Oklahoma City, they hired one in Enid. That was me. So I became, I got to go to our conference in Boston with national, leaders in San Diego and a couple of other places, and I got to learn quite a bit of what we knew about the virus at that time. which has changed a lot since then, so I'd say my information is out of date from back then. But, one of the first patients I took care of in that job down around Oklahoma City, he had no idea he was sick, and then he became blind. He got an eye infection, but became blind, and he had the cytomegalovirus retinitis. He was legally blind. He still rode a motorcycle. He was a little dangerous on that motorcycle, but he didn't go very far from his house. But he, at one point, he was being treated as nearly everyone in this side of the state at the infectious disease clinic, the OU Medical Center. They had a grant to do that, so everyone sent their patients there. And to my knowledge, I know Enid is still doing that, and I think a lot of the states still does. But at one point, he had lived with AIDS because he had the AIDS-defining condition and his CD4 count. At that time, they just did a T-cell count, I think, but it was very low. And he did have AIDS, and at one time, he had lived longer with AIDS than anyone else in Oklahoma. And I was his case manager for about 5 years. So I saw him go through a few infections, but he ended up doing really well. And then you see some cancers on this list on page 340, table 19.1, which is kind of interesting to me because I don't think of cancers coming in when our immune systems are low, but there are some types that are much more likely to happen in that situation. And the person that I called Sam here, he was a construction worker. He looked, I don't know, he looked like Magic Mike, if you know who Magic Mike is. He took advantage of the fact that he looked like Magic Mike. He picked up a lot of women in bars. And although he swore that's how he got the infection, I have no idea, and it doesn't matter. But how he was diagnosed, he was out working on a construction site, and he fell off a ladder, and he had a really severe fracture in his leg that was gonna require hardware. So they did a chest x-ray. They also, and someone I think on his assessment noticed he had like almost a pin egg lymph node somewhere. But it was his chest x-ray that led to the diagnosis of lymphoma, and then they ran more tests and found out that he in fact was sick with AIDS. So all three of these people were sick and had skipped the whole HIV positive, timeline, and went straight to being ill before they even knew they were HIV positive. So they probably had many opportunities to pass it on to other people unknowingly. So that leads us to the HIV/AIDS timeline, which can vary a lot. Some people get sick with night sweats, chills, fever, headache, which is pretty vague when you think about it. You think you maybe have the flu. I would not think that I had developed, I was HIV positive if I, had a few days or even a week of that kinds of symptoms. I would just think I had some kind of bad respiratory virus or sinus infection or something. I wouldn't think to go get an HIV test. Others, and then they get over that, and then they might go on for years before they actually develop some of those AIDS-defining conditions and get sicker and get diagnosed. Others develop those conditions pretty quickly after that. And some do not progress at all. So, I don't know what the situation was with Magic Johnson that he got diagnosed, but I'm sure he got on the best antiretrovirals that were available at the time. Imagine he took them very diligently, and to my knowledge, he's never had an AIDS-defining condition. And he could live to be 80 years old. We do believe that there are people who are HIV positive who never ever convert to AIDS, which that used to not be the case. It was kind of like a death sentence early on because the medications weren't as good, there weren't as many of them. people did not understand the importance of taking them exactly as they were supposed to. They had a lot of side effects, and so we all know, that it's hard for people to take their medicines exactly as they're supposed to. It's hard for me to remember to take my antihypertensive every night. I forget sometimes, so factors in that timeline. One of them has to do with the viral load of the transmitter. So like a person who got the infection from a blood transfusion, they probably got a big dose. Also, it has to do with the number of exposures. If you are someone who perhaps is an IV drug user and you live in a homeless camp with a lot of other IV drug users and you frequently share needles, you probably have multiple exposures to HIV. That increases, that means you're probably gonna progress to AIDS much faster than someone maybe who's a victim of a sexual assault. They have severe, they have mucosal tears, they are infected from that one sexual assault, and then they do not have any re-exposures. And if they're in good nutritional status, they're not under a lot of stress, they have a better chance of just staying HIV positive and not progressing. So how healthy you are to begin with and how well you take care of yourself, and then that whole re-exposure issue. The other thing we know about viruses, just from the flu, you all participated in flu vaccination clinics this year. We know that it mutates from year to year, so that's why, getting the vaccination reduces your likelihood of getting the flu substantially, but it doesn't guarantee it, because that virus that goes around this year is somewhat different than the one that went around last year. There's, of course, we know there's A and B, but there's also little mutations that take place. With viruses, they're smart. And if we, particularly, the HIV virus, when people miss medications, it tends to get resistant to certain types of medications. So, like I said, it's the evil genius. That's my thought about it. Okay. So now this slide may be different than what you have. I went online and looked up a few different numbers. You do not have to know these statistics, except, it's important to know that millions of people have died from AIDS. That was a 2019, I think a CDC statistic. 2017, I think 940,000 had died in the United States. We've got over a million people living with HIV. 20% are unaware of the infection. So those are estimates, obviously. Worldwide, around 5,000 new diagnosed per day, mostly women and minorities. So when I say it used to be a gay, Caucasian men's disease, that's a long time past. That was how it started really in the United States. You probably know with the patient zero, or whatever they call it, was an airline steward who led a promiscuous lifestyle and traveled extensively throughout the world, and was responsible for the initial cases in the United States. Okay, so that about women and minorities, that's kind of important. That has to be, we've got an objective, I think, on culture and things like that. So it's important to know. And then pregnancy risk. So if a pregnant woman is HIV positive and she's not taking antiretrovirals, the chance of her passing on the virus to her fetus is 25%. 25% likelihood the fetus will be infected. If she's on medication, it's 8%. And so the virus is present in amniotic fluid, in vaginal secretions. It's also present in breast milk.
So you can't breastfeed if you have a for HIV?
No, recommended not to breastfeed if you have HIV. Then we look at that 20% of people don't know they have it. So some of them probably are breastfeeding, so there's a possibility they could transfer it to their child unknowingly. And it says, when we talk about who should be tested, it says that should be part of prenatal care. But I know from talking to people who've had babies in the last few years that some of them, as far as they know, were not tested. But the CDC recommends that every woman who goes for her first checkup and gets some lab work, that should include an HIV test. So transmission, I think most of you have done enough reading and watched enough TV and know enough to know that, it's frequently transmitted through sexual mechanisms and also parenterally. We just talked about the perinatal. Body fluids, like tears, saliva, sweat, urine, feces. As far as I know, and I did do a little reading, and there's some people who will tell you that they've never had unprotected sex, and they've been monogamous, and they've never shared a needle or done anything to have a plug exposure. So they believe they've been exposed in one of these ways, but it's really hard to prove. So the thing we would do as healthcare workers is protect ourselves through standard precautions, right? Treat every patient you encounter when you're handling urine and feces and emesis and sputum, and certainly as if it's potentially infectious. Sweat, I don't know how you could do that unless you wore gloves, and even when someone is really sweaty and they shake their head, there's gonna be droplets of sweat go in the hair, so you have to have goggles, I guess, too. I imagine most of us have been exposed to sweat. Maybe some saliva just from people talking and accidentally spitting. But we should treat everyone as if they're potentially infectious and practice our standard precautions. If we always do that, we should feel pretty safe. Regardless of what your patient comes into the hospital with. Because if you think back to the Sam with his broken ankle, nobody thought he was HIV positive, but if they were doing standard precautions, then they didn't have anything to fear. Semen and blood have high, and also vaginal secretions, I think. I'll have to look at that one to make sure. Have high, there's 4 listed on page 341, the 4 highest fluids with concentrations: semen, blood, breast milk, and vaginal secretions. And then the others are a little iffy. But sexual intercourse, the women's, vaginal tissue is fragile, it's mucosa, there can be microscopic tears, it's a fairly large surface, so it's pretty easy for a male to transmit to a female with just basic penis and vaginal intercourse. It can also, the woman can transmit to the man, but that's a little less likely. Anal sex, there's more mucosal tears, it's a high risk activity, so there's a lot more transmission to the receiving partner in that case, male or female. It can be transmitted through oral sex as well. Sometimes you have an area of mucosal damage in your mouth from, swallowed some hot coffee and my tongue's going, and it's kind of sore. Well, it's probably not intact, honestly. So that's possible too. Screening. Now, I don't feel like I'm going very fast, but we're going pretty fast. I guess you'll get to take your break today. Okay, and do an activity. All right. Okay, so who should be tested? Well, according to our book, everyone between the ages of 15 and 65 should be tested at least once. And just a show of hands on each of the campuses, how many of you here in Enid think you've been tested for HIV? Okay. Looks like probably less than half. How about Stillwater? What would you say your percentage was, Mr. Bayer?
Maybe half as well.
Okay, and Thompson?
I think it's around half here as well.
Okay,
A
so,
lot of them for pregnancy, like you mentioned.
yeah, we are really not following the CDC guidelines, aren't we? So, that's typical of the United States. We know what we're supposed to do, but we don't always do it, and even our physicians don't always follow, guidelines. They think, well, this 15-year-old, is not at high risk for this disease. So, generally speaking, they don't always follow through. If they have a high risk, if someone has a high risk lifestyle, they should be tested at least annually. And as I said, the prenatal lab work should include an HIV test. I believe our book says, and I probably should have put it on here, that, if you get lab work before you get married, that it should include HIV. But I don't think lab work is required in Oklahoma before people get married. It used to be. And that was mainly, I think, to test for maybe syphilis. But there are probably some states that still require some lab work for a marriage license, and other states that don't. So you really cannot control that so well. So anytime, maybe you go to a health department and they're doing testing for people who are seeking testing because they have concerns. There should be education to go along with that testing and counseling. They should be reassured about the confidentiality practices. A health department does have to report a new case to the state just to keep statistics. I don't know how they go about that. They might put gender and age or something with it. I really don't know how that is done. I'm not working in health department, but, and I know that they highly recommend and encourage that person to have any people that they have shared needles with or had sexual relations with should also get tested, of course. But I don't know that they can force that to happen. I'm not sure they can even, I don't think they can even force someone to tell their partner. Although, maybe that should be the case, but as far as I know, it's not. So, better practices, teaching would be talking about what is considered high-risk sexual behaviors, and also encouraging people to wear condoms, to wear gloves if their hands are coming in contact with mucosa of their partners, to wear dental dams if they're having oral sex. So really, and also, which we'll talk about a little later, of course, being monogamous or practicing abstinence is much better results than these other things, but these are, better than nothing. And then counseling, even before the results come back, reassuring people that if they do come back positive, that an appointment will be made with an infectious disease specialist, that they'll get started on medications, that they'll, even if they don't have insurance or money, they'll be, there are programs to help them get the medications and also some psychological support, because that would be a very scary, thing to have happen to you, to be diagnosed as HIV positive. I've been tested, I don't know, probably 6 times or 8 or 9. One was when I was taking care of that patient that was the first one in Garfield County. I took care of her a lot, and it was not all that unusual to not wear gloves when you started IVs back then. It was kind of like recommended, but it wasn't required, and we would run out of gloves. So, we started IVs, we emptied drains, we cleaned up all kinds of things. We did a lot of things without gloves, and, so quite a few of the nurses were tested, I think, maybe every 3 months for a year, that had taken care of her. And then I had a, exposure one other time that, I think I maybe was tested once for that alcohol. So, the ABCs of the safe sex are abstinence, being the best way to avoid a sexual transmission, being faithful, having one partner, using condoms, and then, as I said, lubrication reduces the chance of injury to mucosa, and gloves. If your hands look like mine, I always have nicks and scratches in my hands, and I don't want my hand exposed to any infectious body secretion. So, the higher the viral load, I know we've talked about this a little bit, but the higher the viral load of the person that exposes you to the virus, the more likely they are to infect you. But even when that person's viral load is undetectable by labs, they can still transmit the virus. Because being undetectable doesn't mean it's not there. It just means it's at too low of a percentage for our current lab work to pick it up. So, and that's something that people probably believe incorrectly and think it's okay for them to have unprotected sex because they just went to the doctor a few days ago and the viral load's undetectable. Ooh, I can go out and, I don't even have to tell this person if I happen to pick someone up at a bar that I'm HIV positive. I don't have to tell them, I don't have to wear a condom, I don't have to do any of those things, because my viral load is undetectable. But that is a mistake. Okay. Pre-exposure, this is a little bit new. There are a lot of commercials out there. I think the medication I see commercials for is Truvada. There's a newer one, and Truvada is a combination of a couple of different antiretrovirals. But if you have an HIV positive partner, or maybe you work in the sex trade as a prostitute in Las Vegas, you could probably get a prescription for Truvada. And it isn't 100%, but it cuts down the likelihood that you would get the infection. Post-exposure, if you're the victim of a sexual assault and you don't know the HIV status of that person, you might start taking the medications. It's recommended, I think, within 72 hours. The earlier, the better. If you get a needle stick, or I put poor judgment here, you know, someone goes to Hawaii and they're partying and they meet somebody that they just think is the most irresistible, amazing person, and they're having too much to drink, so their judgment is off. And they have a one-night stand or something, get back on the plane, go home, and start thinking, I don't know if that person is safe or not. So they're freaking out, go to your doctor, get on medication for a period of time. And they would test you, I think it's around 28 days. It says so in your book, but it says in your book how long that would be. With the needle stick, when you do not know the HIV status of the person, and I'll give you an example of a nurse I worked with. I worked at a small hospital in Edmond where we drew blood, we drew lab work. The night nurses drew, we didn't have a lab tech working graveyard. And the nurses drew, about, 5 o'clock in the morning, and the lab tech would arrive around 5:30 or so, something like that, So, the nurse drew the labs with a butterfly. She was wearing gloves, put it in the sharps container, but the sharps container was full, and there were several needles pointing upward. And she kind of shoved her butterfly down in there, and she got a needle stick which caused blood to come through her glove. She gouged herself pretty good, and she did not know which needle it came from. And that sharps container contained, lots of patients' blood. You didn't know where it came from. So we went into the protocol and got her started on the cart that was recommended at that time several years ago. The medications may have changed by now. And then I think we tested her maybe every 3 months for about a year, and she was fine. But I think that was a little bit frightening, and they always teach you not to fill a sharps container more than 3/4 full, and also not to, to drop things and don't push them down in. But old habits die hard, and she made a little mistake there, and so she had to take these medications that kind of made her nauseated and not feel very well for a while. Okay. We're gonna take a break here in 15 minutes after this slide, I think. So far, our lecture capture is working. So, again, this is kind of a summary. It says with healthcare workers, it's usually needle sticks, but it can also be a scalpel. And at that same hospital, we had a surgeon who was the chief of cosmetic surgery at OU, but he did some private cases at this hospital, and he brought residents with him sometimes. Well, residents are not as good at handing off scalpels and exchanging instruments with surgery technicians as an experienced surgeon. And I think we had 2 scalpel cuts when we had residents. And one of those people, of course, the patient has signed a global consent when they come into the hospital that includes, at that hospital, it said, if we have a need to protect our clients, we will do HIV testing. The consent was signed. So if that patient's under anesthesia, we went ahead and ran it for our employee. I think that one chose not to take the medication until she got her results back. But because the patient was in a low-risk category, and we knew who the patient was, so that it was up to the employee whether she wanted to take the meds or not. Okay, seems like there was one other thing I wanted to talk about before we took the break. Oh, I wanted to tell you that, and it's a little off the subject, but it's about your last test and the fact that you had quite a few meds on that test. I wanted to tell you that we do not do that just to be mean biatches. The deal, every year, Mrs. Bradley, when our graduates take the NCLEX, Mrs. Bradley actually gets the breakdown. It's, wow, 6 months or so, or maybe even longer than that, close to a year later, and it tells her what areas our graduates were weakest in. So, 2 or 3 years ago, Mr. Baird may remember, I know it's at least 2, but 2 or 3 years ago, we were weak in pharmacology. And so I started adding some more pharmacology questions. And they come, I tend to use the test bank that comes with the book as, and then maybe change it up just a little bit. I think this is my 7th year, but I'm not all that confident in my question writing ability, so I like to use those. I think Mr. Baird's done this enough years, he doesn't use the test bank very much, if any. And I don't know what Ms. Hay does, but, we do that. I do that. I add pharmacology because I want you to do well on your NCLEX. And if you take a question, maybe it's an OB question, and you miss it, it's gonna ask you more OB questions. So if it gives you a fairly easy OB question and you miss it, you're gonna get more OB questions. And if you miss a pretty easy pharmacology question, you're gonna get more pharmacology questions. Because a lot of times I talk to people who've just taken their NCLEX. And, you know, there's 2 of them who took it the same day. One of them will say, man, I didn't have hardly any pharmacology, but I had a lot of psych. And the other one will say, I had a lot of pharmacology, and I only remember 3 psych questions. So it's kind of an interactive almost process where they're looking at where your weaknesses and strengths are, and are you safe in every category that you need to be safe in. So I don't think there's a lot of HIV drugs on your next test. I know you had a lot of pharmacology on that class test. I just wanted you to know that every test question we give you, we're thinking, this is the question that's gonna help them pass, you know, this semester, next year, they're in class. That's what our goal is. If you don't pass, we don't pass either, is the way I look at it. If you graduate here, but you don't pass the NCLEX, we failed you, in my estimation. Unless you're just kind of one of those, crazy learning test anxiety people that I can't figure out how to get what you really know out of you. You know, you're smart, you're capable, you're very, very good. You just kind of freeze up and forget it all when you're testing. I've never figured out what the answer is to that. We'll refer you to some other people and hope they do. But anyway, let's take a 15-minute break. I think that'll be a